Well, good morning to all of you. At the Muslim, thank the organizer for the opportunity given. Well, this is the case history of a 70-year-old doctor. He had undergone bypass surgery 20 years ago. Now he's got recurrent acute coronary syndrome, recurrent episodes of angina. He was admitted in a nearby hospital where he was taken up for an angiographic evaluation. You could see that the circumflex is totally occluded, the left anti-descending artery is totally occluded, and the right coronary angiogram, you could see that there is a diffusely calcified distal critical stenosis. And in the second image, you can see that the vein graft to the LAD is flowing well, and you could also see that there is a critical stenosis in the left anti-descending artery beyond the vein graft anastomosis. Well, they attempted to open up the right coronary artery. They tried crossing a balloon. It was not possible. They wanted to do a rotablator, but then again the microcatheter wouldn't go through. They tried with an OTW balloon. The OTW balloon also wouldn't get across the lesion, so they didn't get a rotafloppy distally. So the patient was referred to us for a possible lacing of the uncrossable distal RCA lesion. So that is how he landed up with us. So our strategy was, we felt that the left anti-descending artery was going to be much easier to be tackled. There is only a short lesion with little bit of calcification. So we told them that this is going to be a much easier procedure for the left system. So we start off with the left system, we'll finish it within half an hour, then move on to the difficult right coronary artery. So that was the thought process like. So the strategy for the right coronary artery is, because it was an uncrossable lesion in the right coronary artery, we thought that we'll go ahead with lacing and go across the lesion, then exchange it for rotafloppy, prepare it with rotablation, then balloon dilatation, and then IVUS guided stenting. So that was the strategy when we started off the procedure. We went through the femoral approach. That was a 7 French guide catheter. That's a good supportive guide catheter. That's a short Amplatz left catheter, and on the vein graft, we tried to, our plan was to get across the lesion with a fielder FC wire, get the microcatheter across, then exchange it for a rotafloppy. You could see in the second frame that there are two areas of calcification. The pink one, it shows the anastomosis. There is a small amount of calcium there. The distal one is a chunk of calcification in the LAD, but then we expected that it's going to be very easy. So we tried to wire with a fielder FC wire. We wired it, but then the microcatheter, that's a caravel catheter, wouldn't go across. So it got stuck at the proximal lesion. That's the anastomotic site, it got stuck. We switched over to a fine cross catheter. The fine cross catheter also wouldn't go across. So we removed the fielder FC wire, tried to wire with the rotafloppy wire. You could see that the rotafloppy wire was not going distally, it was going retrogradally back into the proximal LAD, and we found out the reason for that was that the anastomotic site in this scene, in the frozen image, you can see that there is a shelf-like projection there. That was the reason why the wire was going back into the LAD rather than going forward. After changing the curve of the rotafloppy, we were able to wire it. It went down into the left anti-descending artery. Then we started off with a 1.5 millimeter bar. It was at 180,000 RPM. You could see that it's getting stuck at the initial calcium. There are two areas of calcium. It got stuck at the initial calcium. In the second image, you could see that we went up to 200,000 RPM. It crossed the first calcified area. Then in the third image, you can see that at 220,000 RPM, we were not able to get across the distal calcified chunk of that calcified segment. So we made two modifications. We decided that we'll downsize to an 1.25 bar, and the second thing was we decided that we'll go with a guide extension catheter. That was a guide extension catheter, 7 French comparable guide extension catheter. It was actually difficult for us to get the 1.25 bar even through the 7 French guide extension catheter because of all these tortuosities and the angulation of the vein graft over there. But we were able to get it down there with the help of an activated bar advancement. That's with the help of a dynamo. 125 bar at 200,000 RPM. You could see that it was not crossing. We went up to 220,000 RPM. You can see in the second image that we were trying to force it across that particular area, hoping that in case it got across, got stuck there, we'll have a guide extension catheter. With the help of that, we'll pull it out. Then it was again not crossing. It was almost 3 minutes of bar time. So ultimately we switched over to a New York bar. We had to take a new bar. It was an 1.25, and this time with the help of a judicious push also, we were able to get across the LAD. So you could see here that we were trying to push it a bit hard against that with a power backup support from the telescope. That's a 7 French guide extension catheter, and it crossed the lesion. Once it crossed the lesion, things were more or less easier. We dilated it. We did IVUS evaluation. There was napkin ring calcification, which was dilated, stented, and we were able to achieve a good result. Took almost 2 hours. We thought that the procedure would be over in half an hour time we could switch over to the right coronary artery. But then it took 2 hours. We wanted to stage the LAD, but then he, being a doctor, he told that I'll be comfortable lying like this for another 2 more hours. Please continue with the right coronary artery. Even though we didn't want to do that, but then we were forced to do the right coronary artery intervention at that point of time. So again, cannulated the right coronary artery with a short Amplatz catheter with a good backup support, and then we didn't want to waste time, so we wired it and went ahead with lacing. That was a 0.9 millimeter laser catheter. It didn't go across. Then we switched over to a backup support with the help of guide extension catheter. That's a guide plus catheter. Again the lacing catheter wouldn't go across. Then we did contrast lacing. With contrast lacing we were able to get the lacing catheter a little bit forward, but then it didn't cross the lesion. But then we were able to wire it and do a rotablation. 1.25 millimeter burr. Finally it crossed at 200,000 RPM. Then 1.5 millimeter burr. Again at 200,000 RPM it went across. Then we did IVUS evaluation. You can see so much of reverberation, so much of polishing done to that napkin ring calcification. Then we went ahead with balloon dilatation. Took a couple of long stents, one distally and one proximally, because IVUS revealed that the entire vessel was diffusely diseased, so had to take 2 long stents. Then we started post-dilatation. At post-dilatation, we found out that at that particular area, more proximally inside the right coronary artery, we were not able to dilated. Then we went ahead with an OPN balloon. In the first image, if you concentrate on the first image, you can see that at 35 atmosphere it opens up the vessel very clearly, and then we came back proximally. Again proximally we were not able to dilate it, so you could see that this was a flow inside the vessel. Proximally we were not able to dilate it properly. By this time patient had some hypotension. We looked whether there was retroperitoneal hematoma. Things were better, things were okay, so we continued with the procedure. Then we again did an IVUS evaluation, again found out that the minimal luminal areas was not good for that. So again we switched over to an IVL catheter, 3.5 IVL, 80 pulses exactly at that particular area. We were not able to totally open it up, but then it was almost 3.5 hours into the procedure. Patient has started developing hypotension, so we thought that probably we should stop at that point of time, because we've exhausted whatever devices we had in a cath lab for managing this right coronary artery, and we ended up having a TIMI3 flow inside the right coronary artery with a little bit of under expansion and a good collateral flow into the circumflex artery. So that was the final result, and the IVUS evaluation we made out that at that particular area the minimal luminal area was 5 point something, but then proximally it was 9 plus. So dear friends, the take home message, the learning points for me: all these post-CABG patients, they are extremely difficult to manage. We attempted managing this particular patient with multiple device signage helped us in achieving reasonable results. Short Amplatz left catheter, good backup support, rota with 1.5 millimeter and LAD did not cross at 220,000 RPM. Downsized the rota to 1.25 with a power backup with the telescope, 7 French guide extension catheter. IVUS for optimization. Right coronary uncrossable was managed with lacing with contrast, then rotablation with 1.25 and 1.5 bar. Then non-compliant balloon, angiosculp stent and expansion was managed with OPN and intravascular lithotripsy. Still had to settle down with a little bit of under expansion, but we were happy at the end of the day that we ended up with a safe procedure and a TIMI3 flow, and the patient did well he's doing well for the last 3 months. Thank you so much.